In the intensive care unit at Mount Sinai Hospital in New York City, a family gathers. Gendalina Lara Murillo has been kept alive on a ventilator for the last 5 days.
She's not doing well. She's dying. Very difficult. We know.
With every major organ failing from end-stage liver disease, her family is now faced with taking her off life support.
We have a decision to make. One of the decisions is whether we should take the tube from the mouth and take it out. Does he have thoughts about that?
Say yes.
Okay. So let me prepare you for what may happen. The ICU is at the apex of life and death. We give a little bit of dose of the sedative to make sure she feels no pain. We have a tremendous amount of technology that prolong life. But ultimately, we can't overcome the patient's illness in most cases. They have cancer. They have kidney disease. They have end-stage liver disease. They have these diseases that are life-shortening. After we remove the tube, now if you look at the history of critical care, we don't know how the idea of an intensive care unit was for you to come there with a life-threatening illness and respond to the treatment and get better. Unfortunately, what's happened is that Americans are now coming to ICUs to die. Okay. I'm going to take it out, okay?
Today, more Americans die in hospitals than anywhere else, often after prolonged illness and many medical interventions.
What modern medicine is capable of doing is almost what 20 years ago was considered science fiction. Essentially, you can support pretty much every body system for years because you can keep their lungs breathing and keep their heart beating, keep their blood pressure up and keep their blood flowing. That suspended animation state goes on forever. And so the decisions at the end of life have become much more complicated for everyone involved.
As healthcare costs continue to escalate, there is growing concern over the billions of dollars that Americans now spend each year on end-of-life care.
There's a tremendous pressure now to reduce care to numbers, as though there's an algorithm for every decision. When you look at, Medicare data on expenditures at end of life and what is very glibly termed waste. 30% of all care is waste. That's the new mantra. It's very hard to know what that means. And it's very hard to bring that out of Washington and into a hospital and at the bedside with a single individual facing death.
Hi. Can you squeeze my hand? There you go. I'm going to put your head down.
Robert Bernardini is 47 years old. He had a massive stroke 2 years ago and has been living in a nursing home. His cost of care is covered by Medicaid.
He was here 2 months ago, here, also with pneumonia. He got better. They sent him back to the nursing home and came back in Tuesday. And since then, he's been on the machine.
When Robert came into the hospital with pneumonia, he had a cardiac arrest and was resuscitated. He has now been on a ventilator in the intensive care unit for over a week.
The first 2 days, he was listening to me because I would tell him, Bobby, if you hear me, touch my hands, and he would. But now, I don't know what it is that it's not happening like that anymore.
Nearly 95% of our patients cannot communicate because of either their underlying illness or because of the heavy sedation we're providing. So what happens is that most of the care and interventions are discussed with the healthcare decision maker, who may be a family member or a healthcare proxy. In a perfect world, the patient designates a healthcare proxy and has a discussion about what their preferences would be at the end of life. But many of the patients who end up in the intensive care unit, those discussions have never happened with the critical care doctors. And this causes a tremendous amount of burden for everybody because they now have to make life or death decisions for somebody else. So we know that he had his underlying problems, right? So he has emphysema, and we know he's had a stroke, and his underlying HIV as well. From the standpoint of his brain, it's unclear whether he's had long-term damage from the cardiac arrest, but it does appear that he's waking up. The bigger problem, I think, right now is his lungs. If we're unable to safely get him off the artificial respirator, remove the tube safely, then the next step is what we call a tracheotomy.
What is this?
Right. But there is a tremendous amount of pain and suffering that can go along with that as well. It will certainly prolong his life. The question is, will it improve it?
I don't know what to do about this. Should I just let him keep living in this condition? I don't know. I don't want him to suffer anymore. I mean, I'm suffering, and I know he is also. I can't handle this no more. But I just hope that I make the right choice. I don't know. I really don't know.
These are decisions about whether people are going to be alive or not alive. And if they are alive, if they're going to be living with dependence on life supports or not, or in a quality of life that may or may not be acceptable to them. The risk is that somebody ends up in a position that they absolutely do not want to be in, and they are very vulnerable and voiceless and cannot extricate themselves from that position.
So she is very, very wasted,